So kidneys, you have two of them. You can function with just one, but we have two. They have major veins and arteries that feed and perfuse the kidneys. The kidneys are very dependent on adequate blood flow. That's why we worry about patients with dehydration or low blood pressure, because it can really affect kidney function and potentially kill some of the functional units in the kidneys. Nephrons are the functional unit, and we have millions of them in each kidney, in the pelvis or the main part of the kidney, and these really do a lot of the work in our kidneys. This is a glomerulus or glomerulus unit, and that's all part of the tubules. We have many tubules in each of the glomerulus complex. But you can see how those tubules, they reabsorb water, they excrete water, play a role in potassium and calcium. A lot of electrolytes are either secreted or absorbed in those tubules, so they play a big role. When we give medications to, for example, Lasix or furosemide to excrete water, we're affecting those tubules. Different medications that we give to control blood pressure are really affecting one of the chemical complexes, the angiotensin system within the kidneys, and it controls blood pressure. So all those electrolytes and things that go through those tubules and excreted and reabsorbed really play a big part in our whole body's function. The kidneys themselves, though, play a big role in our acid-base balance, and we'll talk about that in a little bit. Bicarbonate is excreted by the kidneys and helps keep our pH balance on the alkalotic side. Water removal, it works along with your antidiuretic hormone from your brain, baroreceptors, a lot of different complexes within the whole body, but your kidneys are where the water is removed. Excess water should keep your body in a good I-NO balance, right? So we want to make sure you're not excreting too much water. Or sometimes people that have heart failure, we try to get them to excrete more water. We give them things like Lasix that affects those whole tubules, and they excrete more fluid. Erythropoiesis, so the creation of red blood cells. We think of that with the bone marrow, but actually the kidneys play a role in the creation of new red blood cells. Toxin removal, so things that are not required in the body and considered toxins by the body are excreted through the kidneys. We have to be careful, though, that they're not nephrotoxic. They could kill some of the kidneys, so we really want to know if any medications are nephrotoxic. And it plays a big role, though, in those loops, again, to get rid of things that our body doesn't need. And blood pressure control. We'll have a whole slide on this within this module. The angiotensin system really plays a role on our controlling blood pressure in our body. And again, some of our blood pressure medications affect this system, and that's how they help people with hypertension to control their blood pressure. And vitamin D activation. Vitamin D, when we take it orally, not a lot of it makes it through the body. We get a lot of it through the sun. The reaction that I'm going to show you really within the kidney helps to activate that vitamin D. Vitamin D is actually a hormone that does a lot in our body, and we know that there's a big public message out there to make sure we know what our vitamin D levels are. But you need good kidney function to really activate that vitamin D. Okay, so our kidneys' role in the activation of vitamin D. We know we can get some vitamin D from vitamins and foods, but really the best amount of vitamin D, D3, is activated by sunlight in our skin. And really we need calcitrol, which is produced by the kidneys, to make this vitamin D active. And then vitamin D plays a role to really regulate our calcium and phosphorus in our body, and that's needed to really have healthy bone, have bones grow when we're little, and maintain bones being strong in old age and prevent osteoporosis. So the kidneys, through the calcitrol that makes the inactive vitamin D active, plays a role in our healthy bone formation and maintaining strong and healthy bones. Okay, now let's look at this renin-angiotensin system that the kidneys play a major role in with their release of renin, and it really helps to increase blood pressure or decrease blood pressure when it stops producing renin. So it really plays a big role And when we look at different medications, they block some of this renin-angiotensin system to help people with hypertension. So let's look at the pathway. So you have the kidneys, and when you have low blood pressure, the kidneys produce or release renin. Renin reacts with angiotensin, which is in your bloodstream. It lives in your bloodstream. When the renin and angiotensin come into contact, they make angiotensin 1. Angiotensin 1 circulates to the lungs. The lungs convert angiotensin 1 with the ACE, or the angiotensin converting enzyme, from the lungs, makes angiotensin 2. Angiotensin 2 causes vasoconstriction, and if you have vasoconstriction, you increase your blood pressure. Now, along with this, the adrenal glands that sit on top of the kidneys, they help with all of this blood pressure control by producing aldosterone when needed when we have low blood pressure. Aldosterone will also help the kidneys to reabsorb water and sodium. This is another mechanism besides the vasoconstriction that increases blood pressure when we're in danger and not perfusing our organs. So how does this happen again? The kidneys detect the low blood pressure. Remember, I said they're very sensitive to blood flow. They release renin. Renin reacts with angiotensin that's in our bloodstream. When they combine, they make angiotensin 1, goes to the lungs, and the angiotensin converting enzyme converts angiotensin 1 into 2. Once that's in our bloodstream, we have vasoconstriction. At the same time, we have aldosterone released from the adrenal glands that causes the kidneys to reabsorb water and sodium, and that also will increase blood pressure. But the whole system works in a loop. So once the blood pressure is increased enough that you're having adequate perfusion and your water and sodium have reabsorbed and play a role in increasing blood pressure, the renin stops being released from your kidneys. And when you look at different medications, they affect really the ACE. So you stop the conversion of angiotensin 1 into angiotensin 2. That causes vasodilation, so it helps decrease blood pressure. We also have medications that block aldosterone, so you don't reabsorb water and sodium, and those also help to lower blood pressure. So this is a system to help that normally exists in our body to make sure that our organs and tissues are perfused. It kicks off when we have low blood pressure and turns off when our blood pressure is adequate to perfuse. So this is all going on a constant basis as needed. People have things that are broken in this system, and we also manipulate the system with medication to help people with hypertension. Okay, some other really important things that the kidneys produce and control. Number one, bicarbonate helps control our pH. Bicarbonate is an alkalonic chemical or element, so it helps control our pH. If our blood becomes too acidotic, our kidneys will produce more bicarbonate to make our pH go more towards the alkalonic side, and we have to try to live in that normal pH range of 7.35 and 7.45. So it plays a role to keep a normal pH. The next thing is potassium. It helps secrete and reabsorb potassium, and we all know this in all our nursing questions. When you have too high of potassium or too low of potassium, the one big thing we worry about is cardiac rhythms. So either high or low potassium levels in the body can cause your heart to have abnormal rhythms. So we know we have to really try to keep an eye out for that with kidney problems or some of our medications. When we give Lasix, the loops of Henle in your kidneys dilate and you urinate more water, and potassium goes with it because it is not a potassium sparing diuretic. So that's why our patients are getting extra potassium supplements along with their Lasix. So potassium plays a big important role with our heart rhythms. Normal range is usually 3.5 to 5. Always go by what your book says if it's a little bit different, but it should be in that range. So anything over 5 or under 3.5, we really worry about that we're going to have problems with cardiac rhythms. BUN and creatinine, these are really waste products between what we eat and what we need to excrete. They come out in the urine and stool, but really the kidneys play the biggest role on excretion of blood urea nitrogen and creatinine. With kidney failure, these levels start to go up. We look at ratios of BUN to creatinine, so they're really important elements in our blood chemistries to look at when patients are starting to have problems with their kidneys. They start to go up, and we want to make sure that we keep an eye on them and get a range and a baseline where they start with, so we know when they're going up out of their norm. The other thing, erythropoietin is also produced by the kidneys, and I remember I talked about red blood cells. So when our red blood cell production is low, we don't have we have a low red blood cell count. When we look on our labs, we see they have a low count. Erythropoietin is produced by the kidneys, and it causes the bone marrow to make and produce more red blood cells, so it should go up in our bloodstream. When you think about if you ever have patients that you go to dialysis, you can see on their list of meds that they get erythropoietin sub-Q, and this helps them to replace what their kidneys can't do with erythropoietin. Also, patients on different chemotherapies, if it affects their bone marrow and production of red blood cells, we may add erythropoietin subcutaneously to help that bone marrow, because the kidneys aren't able to keep up with that. But normally, erythropoietin is produced by our kidneys and really keeps our red blood cells in a normal range. Okay, so what can go wrong? What do we see in our patients that affect kidney function? And as we know, we can't live without our kidneys. Patients are on hemodialysis because they have chronic kidney disease or they're waiting for transplant, so we need our kidneys. Like I said, you can function with just one, but a lot of our patients are at risk for kidney damage. Aging itself is going to affect medication processing. They're more prone to nephrotoxic drugs. They can't eliminate medications as easy, so they are more at risk for damaging their kidneys from nephrotoxic chemicals or medications we give them. We really have to look at that. Their glomerular filtration rate is going to be lower, so they can't clear things out as much. Remember, GFR, glomerular filtration rate, it's a calculation. It should be above 90 mLs per hour, and that is really, we measure it when we do a creatinine clearance test, and we collect their urine for 24 hours, and we have the jug in ice, and creatinine is cleared by our body at a steady rate, and they'll use that to look at glomerular filtration rate. It's really an indicator of how healthy the kidneys are. Heart failure can affect perfusion of your kidneys, so patients are really at risk for kidney damage and acute kidney failure or chronic kidney failure becoming chronic because of heart failure. You're not perfusing, blood's not coming out of the heart, so it's not getting to your kidneys. I talked about medication toxicities, and we really have to be aware of that when we're looking up our meds before clinical and going through the list. One of the things your instructors want to know is that medication toxic to the kidneys, and you have to be aware of that and how you would detect that and what the safe range is for the patient. Infections are really with Foley catheters, and different older people are really susceptible, the elderly, to kidney infections, UTIs. They become sepsis, and that can really affect their kidney function. And kidney disease in general, there's a lot of different kidney disease out there, things with multicystic, polycystic kidneys that somebody can be born with, and also different reasons for kidney failure. And when you think about it, then they can't control blood pressure, they can't produce red blood cells, they can't convert vitamin D into active vitamin D, and have problems with calcium and phosphorus, excretion of toxins. So all of these things play a role. Perfusion of our kidneys is really regulated by how hydrated we are and our blood pressure. So we want to make sure that we have adequate blood pressures for our patient, and blood volumes and hydration so that we know their kidneys stay hydrated. They get nephron damage when they're not perfused correctly, and you really run into a lot of problems. So your water balance, they can't excrete fluids, so they're going to have water buildup. This just adds to other problems in their body, especially with heart failure. Decreased red blood cell production, so we're not going to be able to carry iron and oxygen to our cells, so they're going to be fatigued, become ischemic, causes a lot of problems. Hypertension, hypotension, because of that whole angiotensin renin system is faulty. pH balance, they become more acidic, and that is also dangerous, being more alkalotic or more acidic. But the kidneys that are damaged can't produce bicarbonate, so they can't keep that pH in a normal, balanced way. Bones can weaken, fractures, osteoporosis, things like that. So all of these things can go wrong, and we really have to watch in our patient and be aware of certain risk factors that they have. Okay, let's look at, we're going to spend most of our time on acute kidney failure, but there's acute kidney or renal failure and chronic. Acute can be reversed if caught in time and with proper treatment, and hopefully resume and recover and have normal kidney function again. Chronic kidney failure cannot be reversed, and that's a picture of a hemodialysis machine. There's different types of dialysis, but that's non-reversible, and I think that's one of the first main things to understand. So acute kidney failure has different causes and different stages. The causes of acute renal failure are classified really by where the insult is coming from. That's where I think of it. There's pre-renal, intrarenal, and post-renal. And I think this image really kind of shows it as far as location and as a cause. So different insults, think of it that way. So a pre-renal cause is a sudden or severe drop in blood pressure. Say they are really sick with sepsis, they're showing shock, very dehydrated. Patient that's had a flu, an elderly patient that's had the flu for 3 days and been vomiting and not drinking anything. That is before the kidneys. So it's pre-renal, it's a pre-renal cause, hypotension. And because of the lack of perfusion to the kidneys, they start to go into the phases of acute renal failure that I'll go into. So that's one of the causes. Intrarenal is inside the kidney, right? That's the location of the insult. There's some kind of damage to the kidney, toxin, drugs, like we talk about the nephrotoxic drugs. It would be an intrarenal cause of acute renal failure. Inflammation, infection, pyelonephritis, glomerulonephritis can all be an intrarenal cause of acute renal failure. Third one, post-renal failure. So it's the location of the causes, I think of it as after the kidneys. So it's a sudden obstruction of urine flow. So say we have a stone gets stuck in the ureter and the urine flow won't come down to the bladder. That would be, and it's going to damage the kidney because of the buildup of fluid. Tumors, injuries, that's one thing you worry about with certain sports. If they get a kidney injury, or trauma, car accident, something like that, it can actually damage something below the kidneys that is a post-renal cause for renal failure. Also, it talks about enlarged prostate. That would be another key thing that sits below the bladder, right? And if it gets larger, the urine's going to build up in the bladder. It can reflux up into those kidneys and cause damage. So those are the causes of acute renal failure. It's really termed by the location of where that insult comes from, pre, intra, or post-renal causes. Now there's phases of acute renal failure that we need to recognize as nurses and know when the patient is going into these phases. The first one is commonly called the initiating phase. We may miss this one. They have a low blood pressure. It only takes about 20 minutes. It can cause something called acute tubular necrosis. You've heard of that, ATN. And because of this lack of perfusion, they start to go into renal failure. And the first phase, maybe there's a little less urine flow, not really a lot going on that we would pick up on, but the disease process or failure has started. Oliguric, this is when you really see a decrease in urine output. It can go down to almost no urine output. And when you have that happen, you get fluid overload in the body, which is going to exacerbate, put pressure on the heart and the lungs. Also, you worry about all the electrolytes, the increasing potassium, problems with calcium and phosphorus regulation, and it can cause a big problem. And this is usually where we see it and pick up on it, because we start to see things in labs and the dramatic urine output decrease. This usually lasts, I think they usually say about 5 to 15 days. Use whatever they have in your book. They'll have a chart in your book. But knowing the oliguric is really where we pick up on it, and that's where we really usually start to act. We want to know people are at risk and always be aware that they're at risk, but it's this oliguric phase, the second phase, where we usually pick up on it because of the decreased urine output. Patients should have 30 mLs of urine an hour. So anything below that is decreased urine output. When we look at characteristics of urine, when it starts to go from the straw yellow, clear color to becoming darker, more concentrated urine, we worry that they're going into renal failure. Certain medications can make urine look darker, so you have to be aware of the whole picture and what's going on with the patient. Next phase is the diuretic phase. This is when the loops start to kick in and you start urinating all this extra urine that your body has held on to during the oliguric phase, but the loops really aren't functioning well. So you still don't get control of all the metabolic processes, the potassium, calcium, phosphorus at this phase. You're losing fluid, but you have to make sure at this phase they don't get dehydrated, right? Because they really aren't able to control the fluid that it's excreting and keep a good balance. Recovery phase is at the end. This is when they've made it through acute renal failure and their nephrons start to recover, and it can take up to a year for this whole process to be recovered. So we really try to get this knowing what their risk factors are, if they're elderly, if they've been sick, if they're dehydrated, what medications they've been on, have they had episodes of low blood pressure. Only takes 20 minutes of a low blood pressure to start killing off those nephrons and put somebody in acute renal failure. So this slide, I'm not going to go into chronic that much, but acute I think is a little bit more complicated. You have your causes: pre-renal, before your kidneys; intrarenal, within your kidneys; post-renal, after the kidneys. They're all causes. And then you have 4 phases: initiating, oliguric, diuretic, and recovery. And they all have really classic characteristics in those phases.